You would think that after centuries of knowing migraine, neurologists have got it all sorted out. Perish the thought, because migraine is still one of the top head scratchers in the neurology clinic. From understanding its cause to resolving its treatments, migraine continues to challenge and embarrass neurologists every day. And one of the gauntlets that migraine throws at the specialty is how to understand the different ways it can manifest. By definition, migraine is a disabling headache that lasts 4 to 72 hours and is accompanied by nausea and heightened sensitivity to light, noise, or smells. But for many people, migraine is anything but the above definition. Neurologists therefore have had to come up with subtypes and variants of migraine to make any sense of it at all. In this podcast, I will run down 10 migraine variants that make it such a strange disorder. 1. Retinal migraine. This is migraine associated with loss of vision in one eye, and it is thought to be the result of spasm of the arteries that supply the retina at the back of the eye. Retinal migraine tends to affect women in their teenage years or in their 20s, and they usually also have a history of migraine with aura, one of the subtypes of migraine. The episodes of visual impairment last 5 to 20 minutes, and the headache develops during the episode or afterwards. Curiously, headache may be completely absent during retinal migraine. And worryingly, about 40% of cases will progress to permanent visual loss. Luckily, aspirin may help to treat it. Number 2, ophthalmoplegic migraine. This is recurrent severe migraine that tends to start right from childhood. And its calling card is the associated weakness of the eye movements that it causes, something neurologists call ophthalmoplegia. The weakness is often due to impairment of the oculomotor nerve, one of the nerves that controls most of the muscles that move the eyeball. Because this nerve also controls the eyelid and pupillary muscles, ophthalmoplegic migraine is typically associated with a droopy eyelid called ptosis and a dilated pupil on that side called mydriasis. The ophthalmoplegia usually develops within a week of headache onset and it persists for a few weeks. The cause of the ophthalmoplegia is inflammation of the nerve, therefore anti-inflammatory steroids may help in the treatment. Number 3, vestibular migraine. This migraine variant occurs in people with a history of migraine who have had at least 2 attacks of vertigo, whether with or without a migraine attack at the time. Indeed, headaches co-occur in only 50% of patients with vestibular migraine. The attacks of vertigo may last from seconds to days, and they tend to occur in clusters. You can understand why this can be challenging. And to complicate matters, the vertigo may be accompanied by hearing loss, ringing in the ears, also called tinnitus, and abnormal jerky eye movements called nystagmus. We fight over this diagnosis with our ENT colleagues. Number 4 is migraine anxiety-related dizziness, also called MAD, M-A-R-D. This is perhaps a grade above vestibular migraine, as it is defined by the association of vertigo with anxiety and impaired balance. Number 5 is migraneous thoracalgia. This is migraine that manifests as chest pain, so it is also called thoracic migraine. To make it a difficult diagnosis to make, it is not accompanied by any headache. Migraine can also manifest as pain in other body parts. Therefore, there are such variants as isolated recurrent limb pain, isolated facial pain, and abdominal pain. It just goes to show how much migraine is much more than a headache. Number 6, familial hemiplegic migraine. As its name implies, this is migraine that is associated with weakness of one side of the body. And also, as its name suggests, it is a disorder that runs in families. And depending on the causative genetic mutation, it has been classified into FHM1, 2, and 3. Familial hemiplegic migraine is, however, probably a misnomer, as the problems that accompany it go beyond paralysis. Amongst its other symptoms are ataxia or unsteadiness, nystagmus or jerky eye movements, and something called elicited repetitive daily blindness, ERDB. This is blindness that is triggered by rubbing the eye, by exposure to direct light, by transitioning from dark to light, and by standing. And to make matters worse, familial hemiplegic migraine may be complicated by confusion and coma. And just as hemiplegic migraine can be familial, it can also be sporadic. So the absence of a family history is not particularly a reassuring one in this case. Number 7, status migrainosus. This refers to prolonged migraine attacks that may last more than 3 days. For some reason, status migrainosus tends to favor people with a low attack frequency of their usual migraine headaches. And the reason may be situational, as it can be triggered by stress and by poor sleep. Number 8, something called cluster migraine. This is not, as you may think, migraine occurring in clusters. No, it is migraine presenting with features of cluster headache in which neither of the two disabling disorders dominates over the other. The headache in cluster migraine is described as an intense burning or knife-like headache that is only occasionally throbbing. Like cluster headache, it frequently occurs at night, and the victims are often restless, and they may have watering of the eyes and the nose. This variant is a hard one to swallow for some headache experts, who have suggested that it be called migraine with cranial autonomic symptoms. The case of a rose by any name, you might say. Number 9 is migralepsy. This is also called migraine aura-triggered seizures. Migralepsy describes migraine aura which is accompanied by a seizure or which is followed by a seizure within an hour. To muddy the waters for the neurologist, the seizures may be on the same or the opposite side of the headache. Suffice it to say that this is too controversial a concept for some neurologists to swallow. And number 10 is the Alice in Wonderland syndrome. Finally, neurology meets fairy tale in this one. Alice in Wonderland syndrome in this context refers to migraine episodes during which sizes of objects appear distorted. They might appear large or small, called macropsia and micropsia respectively. The episodes may also manifest as a body part getting bigger or getting smaller, macrosomatogonia and microsomatogonia respectively. It may also manifest as a distortion of time. It is important to point out here that migraine is not the only cause of the Alice in Wonderland syndrome, so don't jump to conclusions when you see an arm or a leg growing larger than a house. Thank you for listening or watching this podcast. If you found it interesting or enlightening, don't forget to click the like button, and perhaps better yet, click on the subscribe button, and this could be in the YouTube, the Apple or the Spotify channels. And whilst waiting for the next episode of the podcast, why not check out my website called Neuro Checklist, or perhaps get a copy of my book called Surfing the Brain. Thank you very much for your time.